I'm Dr. Juan Alejos. I'm a pediatric cardiologist working at Mattel Children's Hospital, UCLA, director of the Pediatric Pulmonary Hypertension Program there. Hearts with Hope is a nonprofit organization. We started about 11 years ago. Actually, initially, the first steps were taken over 20 years ago. After my father passed away, my father was a pediatrician who had trained in Peru. After he passed away in the early 90s, I went back to visit where he had trained, kind of a connection with him, and just happened to, as I was leaving, I offered to come back and give lectures, and the medical director of the only children's hospital in Peru told me, instead of giving lectures, we would much rather have you show us what you do. And I mean, that is an idea that never struck me before, but the first mission went back with myself, another cardiologist, and a surgeon, and we did a few cases. And I mean, it just, once I did that the first time, it kind of caught the fever. I've been working at that ever since. And I think I took about a 5-year break when, just due to manpower issues here in the States, in terms of our own hospital, I really couldn't get away. But then once I started again, I realized I needed to form my own nonprofit. We started out kind of covering South America, Latin America. We went to El Salvador. We're going to Honduras, Bolivia. But now, actually, we changed our mission statement. Once we found out that we were successful, we actually went to the Philippines last year. And what we found out, or what we realized, was that you can bring one child over here and do the surgery, let's say at UCLA or any other hospital, at a cost of, $150,000, $200,000, depending on how complicated it is, just the cost of healthcare here in the United States. But for that same, let's say, $100,000, we can treat probably about 40 kids in another country, in another underdeveloped country. We can treat about 40 children or more. And basically, our only limitation, let's say we had the $100,000, our limitation is not the funding; it's actually the time, because it's a much better situation. You can do a complete cardiac surgery in Peru, for instance, for about $5,000 from start to finish, which, here in the United States would barely let you sit on a hospital bed for 5 minutes. It definitely showed us our dollar can go a lot further. Every donated dollar can go a lot further. Our goal when we do this is we don't go and take over. We go and work alongside the physicians, the nurses, the echo techs, basically the whole healthcare team in the other country. We go and work alongside of them, and we commit to a 10-year commitment wherever we go, with the idea that we're helping them develop a program. We tend to go to the same hospital in the city. When we develop a relationship with them, we kind of develop a team, work with a team that's local. Basically, they become like the scouts, and find patients that we should consider, and then we work with them to evaluate them, that we can then, have our cases. And as we do that, we're actually teaching them, that hospital, how to select cases. What kind of patients are good, what kind of patients are, good surgical candidates, what kind of patients are not good surgical candidates. We've seen, for instance, in one city in Peru that we've gone to, the first year we went, they presented us with a list of 50 patients, of which I believe 40 of them were not operable candidates. Just for different reasons. Some of them had pulmonary hypertension. Some of them had other reasons that made them not operable candidates for congenital heart surgery. In this last year, of the ones that they showed us, 49 of the 50 were operative candidates. So they've come a long way in their screening, and that's kind of our goal, is to teach them to be able to do all this. We've done some really impressive things, which, is really a good feeling for us here, because it just shows that we've given them the confidence to go ahead and do this on their own. The biggest thing is supplies. For instance, a lot of supplies that we use here, the cost for them is the same here as it is there, but the income for people, let's say in Peru, is much lower. So it's very difficult for them. They were developing an insurance program for children, which included things like that, congenital conditions, but since they did not consider congenital heart disease in that group, because they thought that there was no way that it could be successful. And since then, we've managed to change their minds. So now they have a kind of an insurance program, but still they have a shortage of supplies. They just don't have the organization that we have here and budget. Basically, they replace supplies as they use them. So instead of, for instance, here where we have a central supply where we have 20 of this or 20 of that, as they use them, they order another one, and then it depends on going through all the bureaucracy of the government approving the purchase and then finally buying them. So they actually may operate for a month and then be stuck waiting for supplies to come in so they can do any more surgery. The first time I went with just the three of us, I recruited a few people who I work with who were interested, and kind of went with a small group of like 6 or 8 people, including the nurses, including anesthesiologists. I think people would hear us as we came back, and just the discussions, and as people heard, they became interested, and then the missions began to grow more and more. I mean, to the point where one of our missions is a 2-week mission where we take 70 people. That we expanded to include dentistry, and basically had more people than we had spots. And as time progressed, people started finding us on the internet or by word of mouth, and we started getting interest from other people in other countries. We have a cardiologist from Israel and Spain who've accompanied us. We have students, undergrads, medical students, and residents, and it's just continued to grow. And I consider that part to be an important part for us as well, because I realize that I can't do this forever, and I want to hopefully inspire some of the younger doctors coming out that this is something feasible to do. The interesting thing is one of our team members who goes with us on missions regularly now, when he first got exposed to this, he was Peruvian, and he was very pessimistic that something like this could work. And then when he went on one mission, he turned around and tells everybody, I was totally wrong. I mean, he realizes our goal, we're not going to fix every single heart lesion that's out there, but we're inspiring them so they can feel like they can. And they are making progress. So I think, right now, when, we pretty much have a long list of people, and people email us along the way saying they're interested if we ever have a spot. So when we plan a mission, we just go, we fill it with people, with return people first, and then we go back to those people and ask them if they're interested, and we are able to fill our missions. But we have a lot of kind of what we call veterans who've been with us on multiple missions and keep coming back looking for more. I realize that in a way we've had kids that we don't treat that would basically not be candidates for surgery here. We'd be very conservative here. Unfortunately, there we don't have the luxury because we don't have the time to wait 3 weeks for surgery because we're not going to be there. Then we realize that is the most difficult part, being the person who, in essence, decides who needs surgery, who gets surgery, and who doesn't. We have kind of a limited number of spots and a limited time. And for us, we try to be as impartial as possible and basically look at which kids can wait another year. And we try to communicate with them. And I guess the two things that stand out to me is, one of them, we found out that in certain countries, unlike the United States, where if you lose your cell phone, you can keep your cell number. In some countries, it's just easier if you lose your cell phone or it gets stolen, is just to get a brand new number. So a lot of families that we tried to reach out to the next year, their cell phone numbers they'd lost and they'd changed, so we couldn't get a hold of them. So we realized that we learned our lesson, that we had to start asking for not just cell phone numbers, but landlines and relatives and friends, so that we basically left with each patient with half a dozen numbers so that we could get a hold of them when we came back. And the other kind of story for me was, we saw a little baby one year on the first day, and the baby had probably croup or had a bad respiratory illness. And typically here we would have sent the baby home and said, come back a couple of weeks after the illness clears. But if we did, we would have been gone. Nobody there could do the surgery, and this baby's lesion was basically he wouldn't be alive the next year for us to come back to operate on. So we admitted the baby and gave him antibiotics and hydration and respiratory treatments. And after 1 week after doing that, we went and met with the family, with the surgeon, anesthesia. We told them we were willing to do the surgery, take the risk, and the family understood what the risk was, that the baby may not survive the surgery. But we did the surgery that Monday, and the baby flew and was home by Friday. It's a good feeling, knowing that we're helping people just because that's what we're trained to do, not because there's a paycheck or a salary or any reward out of it. And these families, they're so grateful. They bring you gifts, small gifts, chocolate, bread, things that are special to them, and it's just, out of just complete, total gratitude. And it's a really special feeling. It makes you really realize that what we're doing is just what we were trained to do. We're not dealing with insurance authorizations or anything like that. We're dealing entirely with the child's life and the fact that we have the ability to save it. My name is Juan Alejos, and I'm aware that I'm rare.